Well, hello, everybody. My name is Melissa Mazor, and I am a nurse scientist in the Community Outreach and Engagement Program at the Tisch Cancer Institute. And I am so delighted to be with all of you today. So to start, if we can go around and please introduce yourself and provide just a very brief background about yourself and your role in cancer care.
Hello, everyone. My name is Christian Rolfo. I'm a professor in medicine at the Sinai Icahn School of Medicine at Mount Sinai, and I'm the Associate Director for Clinical Research at the Center of Thoracic Oncology. My focus of interest is cancer care for thoracic oncology patients, and also specifically, I'm working in drug development and biomarkers in liquid biopsy.
Hi, I'm Dolores Moorehead, and I work for the Women's Cancer Resource Center, where I am a Community Engagement Director and Client Support Clinician. And what that includes is I provide patient navigation to our clients that we serve. I also provide therapy to them and lead support groups and work with different researchers around the needs of diverse populations.
Hello, everybody. I'm Lavern McDonald, and I'm a community scientist with the Icahn School Mount Sinai Project. I'm also a social studies teacher at a small independent school in Manhattan, and I was diagnosed with lung cancer in 2018.
The first step is the relation and relation with the team, because we are a team, so we have also other players that are there, more, for example, nurse practitioners, people that is able. I think everyone is playing an important role, and sometimes the patients identify with somebody from this team that is not specifically the doctor. So if we found this person that is the connection with the team, we need to profit that. So I don't need that the patient is completely connecting with me to tell me the things, because sometimes patients are not, some patients are not telling all to the doctors because they feel that if I say something that I'm not feeling well or I have some toxicity, I'm afraid that they will stop the treatment, and they have more confidence with a nurse, for example. So we need to communicate and increase the communication in the team to be very alert of all these things in disparities. But also we need to, as a doctor and as a team, try to avoid the implicit bias. So sometimes you have assumptions that I believe that these patients will not be able to participate in these trials, or I believe that this patient will not be willing to go through this technology or new research part that I have. So this is putting another step in I would say, the disparity and discrimination sometimes of the care. So we need to be very, very careful. So I think these kind of actions, going to church, and we did that, for example, during COVID pandemic, trying to engage for vaccination, going to church and going to schools and engaging the people from there. And also have diversity in the team care. This is very important, because if you see a doctor or a nurse or an MA that is representing you, your values, your culture, your cultural or even your religion thoughts, that is also creating communion, and that is very important for reduce disparities.